I'm delighted to introduce to you Dr. John Coveney, our paediatric specialist registrar in Wexford General Hospital. He graduated from medical school in UCD in 2015 and went on to start paediatric basic specialist training in 2018. He's worked as an SHO and registrar in the Rotunda Hospital, Temple Street, Our Lady of Lourdes in Drogheda, and the National Maternity Hospital in Holles Street. He's in the first year of higher specialist training in paediatrics, and he's been placed here with us at Wexford General Hospital since July 2020, during which time he's been a great asset to our department. He has a special interest in paediatric emergency medicine and undergraduate and postgraduate education, and has been involved with a number of projects in our department, which he's going to present under the title of Research and Quality Improvement at the Paediatric Department of Wexford General Hospital. So handing over to John now.
Hello, good afternoon, and thanks very much for attending this presentation. John is my name. I'm a paediatric SPR here in Wexford General Hospital, and today I'm going to be presenting about a number of paediatric research, audit and quality improvement projects that have been going on in Wexford General over the past year. In terms of the plan for the next 30 minutes, I'm going to talk about a number of different projects. The first will be a neonates quality improvement project regarding the early onset sepsis calculator and how it's been implemented in our neonatal unit. The second is a project looking at SCID screening that's been done in our maternity unit over the past couple of years. The next project is a project regarding diabetes audit, and there's two separate projects that have been done as part of our diabetes audit. I'm going to move on to a drug cardex audit that was done late last year on the paediatric ward. And I'm going to finish with looking at a neonatal research project that we have started and yet to complete, but I thought it would be interesting to update you all on. Now, a lot of the doctors who have started here with us have only started in the last few months and haven't got a chance to move around Wexford. And I thought I'd show them a few pictures of some cultural highlights and some landmarks of the county to give them some ideas of where they might be able to travel around during the next month as the restrictions are easing a little bit. I've also used the pictures to break up the presentation as I move from talking about one project to the next project. So I'll move back to the introductory title, and that's the first picture, and I'll move on, and that's the second one. And what I've also done is I have a prize for anyone who can put into the chat in the presentation the names of all 8 pictures as we go along through the presentation. So that aside, I'm going to start with the first project that we want to talk about, which is a quality improvement project that is ongoing in our neonatal unit. Early onset sepsis is a rare but potentially devastating condition that occurs in approximately 1 in every 2,000 deliveries. The primary risk factors for early onset sepsis are maternal group B strep carriage, prolonged maternal rupture of membranes, and maternal fever in labour. The introduction of prophylactic antibiotics for well-appearing infants has led to reduced incidence in sepsis. As you can see from this diagram produced by the American Academy of Paediatrics in 2010, the introduction of this policy has coincided with a significant drop of early onset neonatal sepsis from about 1.5 per thousand live births down to about 0.4 per thousand live births. And this hasn't changed. During this time, there was no change in late onset sepsis. So this would suggest that the policy of giving antibiotics is successful and prevents this serious condition. However, there is a downside to the policy in that a large proportion of well infants receiving prophylactic antibiotics leads to side effects, including the separation of these infants from their mothers, the inhibition of breastfeeding establishment, and there's the potential, although unproven, there are some concerns that this policy has led to changes in the neonatal gastrointestinal tract flora, and that there may be links with this and atopy. Our previous policy, which was in line with international and national policies, did recommend prophylactic antibiotics for those with septic risk factors. In California, in the last number of years, a study group attempted to assess was there a potential to risk stratify infants for early onset sepsis, and they looked at a number of different variables. They performed a massive cohort study with over 200,000 infants involved, and they tried to stratify the risk of sepsis using a number of variables. These included the child's gestation, their GBS status, the length of their rupture of membranes, the highest maternal temperature in labour, and whether or not mom received intrapartum antibiotics. Based on this cohort, they were able to generate a calculated risk of sepsis per 1,000 live births in each child. And they came up with a policy where prophylactic antibiotics were only given to children with the risk of sepsis greater than 1 in 1,000, while all other children were observed on the postnatal ward with 6 early checks of their vital signs and were only given antibiotics should they become unwell or were their vital signs abnormal. They found that they had a 50% reduction in antibiotic use in term infants with no increased incidence of early onset sepsis. This calculator is only aimed at term infants and is not aimed at preterm infants. They published the results in 2018. In early 2019, the tertiary maternity hospital in our network, the National Maternity Hospital in Holles Street, implemented this policy. They published the results from the first 15 months of this policy's implementation in April 2020, and what they showed was a 43% reduction in the use of antibiotics in term infants. In Wexford General Hospital, our CNM Fiona and Manju, one of our senior staff nurses, with the support of my predecessor, Dr. Lydia Healy, have championed the introduction of this policy. On this slide, I show a couple of screenshots that show how the calculator is used in practice. On the left-hand side, there's the variables that we talked about earlier, and you input the variables into that part of the calculator for each patient. On the right-hand side is how the calculator generates a risk of sepsis. If the risk of early onset sepsis is greater than 1 per 1,000 live births, then the child receives antibiotics. However, if the predicted incidence is less than 1 per 1,000 live births, the incidence is observed on the postnatal ward. We introduced this policy in December 2020. A group of SHOs have audited the performance of this policy. Niall, Megan and Victoria, who were here in the last 6 months, performed an audit of admissions between January and March 2020 and found that approximately 1.5% of all children delivered here were being admitted to the special care unit simply for prophylactic antibiotics. A re-audit that was just completed in the last couple of days has shown that the implementation of the policy in the first 3 months of 2021 shows that only 0.2% of all infants were admitted just for prophylactic antibiotics, and that these infants accounted for 1.2% of all SCBU admissions rather than 10% of all SCBU admissions in the first 3 months of last year. Of note, there was no cases of early onset sepsis either in the neonatal unit or that have been admitted to the paediatric ward during the study period. So in essence, the implementation of this policy has seen results consistent with the results that we're seeing both internationally and nationally. And I think this project highlights how a research project performed in California and published in 2018 led to policy changes in a tertiary maternity unit in 2019 and in our maternity unit in 2020. It really shows from a research point of view how small the world has become. So here's another beautiful Wexford landmark. And using that, I will segue into the next presentation. This is also a project done as part of our maternity services, and it's mainly done on the postnatal ward. And it was a quality improvement project that was initially performed by my predecessor, Lydia Healy, and Dr. Christabel, one of our current regs, has taken up this project in the last couple of months. SCID, for those who are not familiar with it, is a severe combined immunodeficiency. And what some of us might remember, in the past, it was the condition where the child or the boy was treated in a bubble because they were so susceptible to infection. Now, the treatment of the condition has improved significantly over the years since that. I think that those pictures were made famous in the 1970s and 1980s. It is still a condition that occurs. It's a condition that occurs significantly more frequently in the travelling population in Ireland. And from 2017, it was recommended that all children born to parents who are members of the travelling community had an FBC sent at birth to screen for SCID. So we implemented this policy where implemented this project where we looked back at a period from January 2017 to October 2019 to see how compliant we were with this national guideline. What we found over the 2 years and 10 months period was that 30% did not have their screening test done in the neonatal period, and 16% of children didn't have any FBC result on the system. And we actually found that things were worse in 2019 compared with 2018. So I suppose we implemented a quality improvement. We took a quality improvement approach to the project, and we made a plan, and we acted on that plan, and then we studied the results. The first thing we did was we contacted the families of those without an FBC and arranged for catch-up screening. And then in terms of the quality improvement initiative, we had meetings with our risk department, our CNMs in the maternity unit and the special care unit. We educated staff and circulated guidelines, and we developed a quick glance flow sheet. We re-audited this year, and we looked at the 12 months in 2020. We found that there were 62 children eligible for screening, and only 2 had missed screening at birth. So this shows a much improved rate of screening within this population. We plan to continue to audit. We plan to continue to contact those who've missed their screening to arrange for screening. One thing that is of interest is that with newborn screening, planning to introduce SCID to the list of conditions which are checked for on the heel prick test or the newborn screening test, this work will actually become obsolete in the near future, as we will not need to do the targeted screening program for children born to parents in the travelling community. And again, another iconic part, or an iconic building maybe in Wexford, which allows me to move on to our next project. So I want to talk a little bit, before I talk into this specific project, just about the diabetes service in Wexford. For those of you who don't know, we have a population of approximately 80 children that attend our clinic with diabetes. A large part of our clinic is Deirdre Bowers, who is an incredible diabetes clinical nurse specialist. She set up Diabetes Wexford, which is a charity that supports the families and the children with diabetes who attend our clinic, and they do exceptional work. Also involved in the clinic in a massive way is Dr. Wallace, who's one of the co-chairs of this meeting today, and she's been involved in the clinic for a number of years. And a newer colleague who's more recently been involved in the clinic is Dr. Atia Kaleem, who's recently joined our team. And so they provide an incredible service for the children in the county with diabetes. For a number of years, they've also been leading the way nationally in auditing the clinic's performance against UK National Paediatric Diabetes audit criteria. They're really ahead of their time in Ireland. A national audit is a priority at the minute for the national clinical programs for diabetes and paediatrics, and it's planned to be rolled out this year, although it's been in place in Wexford for a number of years already. Based on our experience with the diabetes audit here, we've been working with Dr. Nuala Murphy, who's the national lead for diabetes services in children in Ireland, and we're using our experience of audit here to inform the rollout of the national diabetes audit. So moving on to the specific project in question, this year 3 of our SHOs, Niall, Connor and Anas, performed the audit, and they presented some interesting findings at the Irish Paediatric Association conference last December. They audited the service from September 2019 until September 2020. And the first table here is an overview of the patients we care for with their ages and their comorbidities. They audited 85% of the patients attending the service with an age range of between 2 and 17 years and a mean age of 17 years. Unsurprisingly, all but one had type 1 diabetes, and a small number had associated autoimmune conditions. One aspect that they looked at specifically in their research was how, in response to the coronavirus pandemic, there was a change in the way by which we did our clinics, and we moved to more virtual clinics from face-to-face clinics. First of all, to note that the National Model for Care recommends that children are followed up between 3 and 4 monthly, or that they attend 3 or 4 clinic visits per year. You can see from the results here that while some of the visits were online this year, we perform well above the lower limit of that target for 3 visits a year, and for the male children attending the clinic, we're pretty close to the 4 visits per year target, and we're not very far away for the female patients attending the clinic. So I think that's something that is worth celebrating. The focus of the paper was how the first wave of COVID affected the children's HbA1cs, or which is a marker of how well controlled their diabetes is. As we can see from this graph, approximately 1 in 4 visits over the period studied was a virtual appointment. And we can see, interestingly, that in the period prior to March 2020, from September 19 to March 2020, the average HbA1c measure at a clinic was 70.8, whereas after from March onwards, the average was 67 millimoles per mole. This, I suppose, explains what had been going on. So you can see that no HbA1cs were taken during April and May of 2020 due to the restrictions imposed. But you can see that there was a significant reduction in the HbA1c average when you look at June 2020 and you compare it to the 2 or 3 months prior to the pandemic. Interestingly, a number of European studies have shown similar findings. One study from a cohort in Barcelona, and another from an Italian study have found similar results, where the HbA1cs have dropped over the period of the first lockdown. Authors hypothesized that modifications in lifestyle and slowing down of routine activities and paying more attention to insulin therapy and glucose levels could have led to this reduction. I suppose in our study, we're not 100% sure why this reduction was there, but it is something that is interesting nonetheless. So moving on to the next study, I have another very iconic Wexford location, somewhere where all the junior doctors could do with the day out in, I think. So we'll move on to the second study that had been done as part of our diabetes service, and this was done by Irina and Livia, and supervised by Dr. Wallace. So they're 2 of our paediatric registrars here. What they did was they compared March to November 2019 with March to November 2020, and they were looking at how the pandemic affected total presentations or total admissions to the paediatric ward, and how they affected admissions of children with type 1 diabetes. What they found, very interestingly, was that there was a very, very significant reduction in the total attendance of children when you compare the 2 periods, a greater than 50% reduction in total ward admissions. And I suppose this is something that has been seen internationally and is in general being put down to the social distancing and respiratory hygiene methods that have been put in place, and these we feel have reduced the incidence of viral illness, other viral illnesses outside of COVID amongst the paediatric population. As everyone working in paediatrics knows, we've been very fortunate that COVID does not seem to cause a significant burden of illness for children, and we haven't seen a large volume of COVID-related illness in our paediatric ward. Looking specifically at children with diabetes, there has not been the same reduction in incidence of attendance. We've had a slight reduction in the admissions of children with diabetes not in DKA, and essentially no change in the number of admissions in children with diabetes in DKA over the study period. What this is suggesting is that children are still presenting in the same frequency, roughly speaking, with diabetes post or during the COVID pandemic as they were previously, in spite of the fact that general admissions have reduced significantly. And again, another very important cultural location in County Wexford, which allows me to move on to
another audit that's been performed on the paediatric ward. Is an audit which looked at Cardex prescriptions on the ward, and it was done by Irina, one of our registrars, with Mihaela, one of our SHOs, under the supervision of Dr. Wallace, done in October of last year, and was presented at the Irish Paediatric Association meeting in December. With the audit, they found a number of parts of our practice which compliance with was excellent. So including a label address graph on each page of the Cardex, recording the date and weight on admission, recording the date at which weight was measured, ensuring that intravenous fluids were correctly charted, ensuring that a prescriber's signature was in the back of the chart, and also including the medication dose was using the correct units.
So they also found a number of areas where we could improve on our performance. The first being the use of generic medication names, which was only present in 77% of the medications audit. The allergy status not being noted in a number of charts, it not being specified whether the chart was one of a sequence or not, and then the lack of prescribing in block capital letters. So the results of this audit, as well as being presented at the Irish Paediatric Association, were presented at a study day, or sorry, at a teaching session within the hospital. And there's plans to re-audit in the near future to see if we've improved our performance in the areas where improved performance was required. So this, I think, is the second from last very important cultural location within Wexford, which we probably aren't allowed to go to yet, but hopefully we'll be able to attend soon. So the final project I want to talk about is a research project that I'm involved in and have been ably assisted by pretty much all of the NCHDs working here at the minute. And it's a project related to vaccine hesitancy. In 2019, before we'd ever heard of COVID, the WHO had listed vaccine hesitancy as one of the biggest threats to global health. They define vaccine hesitancy as a delay in acceptance or refusal of vaccines despite their availability. The project that we were doing was focusing on primary childhood vaccinations specifically. As most people know, these vaccines are given at 2, 4, 6, 12, and 13 months of age. In the past 10 years, with the exception of the BCG, which is in blue there, and you can see really its rates of take-up plummeted in 2015 onwards as it was removed from our vaccination schedule. With the exception of that medication, nationally, approximately 90% of the population take up all of these vaccines before they reach 1 year of age. If you want to look at Wexford specifically, we do a little bit better than the national average, and with an uptake in the population on average of about 92%. So I suppose the purpose of the project was to look and see if there was a way to address vaccination uptake within this group and to increase that percentage a little bit. The question we ask ourselves is there a way to identify those infants who are not likely to be vaccinated? There's a number of different vaccine hesitancy questionnaires, but in general, they're very long and wouldn't be appropriate to use on a postnatal ward. So what we want to do is find a way that we could quickly sieve, for want of a much better term, patients, or screen them and find those who are at high risk of not completing vaccination. And then in the future, we want to look at implementing interventions for those groups to see if we can increase vaccine uptake among the group. So, as I said previously, there's a number of questionnaires that we evaluate, but they're usually long. They're usually 20 to 30 questions per questionnaire, and they're just really too long to be used in any serious way in a postnatal ward. And also, internationally, no questionnaire has been validated for use on a postnatal ward. So what we did was we adapted a single item question from one of these questionnaires and trialed it on our postnatal ward. The question is relatively straightforward. It's a single question and asks mothers what are their plans for vaccination with 6 possible options. So on the board, it's not color-coded, but I've just color-coded for the intervention. The first 2 options, which state that they'll allow their baby to have all recommended vaccines and either have no concerns or only a few minor concerns about their safety, will be considered non-hesitant responses. The other 4 responses, saying that they either have a lot of concerns about vaccine safeties, would like to delay or not at all have some vaccines, will not have any vaccines, or unsure about vaccination, these are seen as vaccine hesitant responses. In one study, those who gave an answer within the vaccine hesitant or any of the answers in the red accounted for 80% of those who did not receive vaccines in comparison with those who answered in the top 2 answers. Therefore, we're hoping to show that this questionnaire is able to do the same thing on a postnatal ward. To date, we have enrolled approximately 183 mothers in the project, and we found about 8% or 15 have been vaccine hesitant. Our recruitment started on the 5th of February. It was delayed a little bit by the 3rd wave of COVID. And we've managed to reach approximately 75% of those delivering since that date. Our plan is to continue enrollment until we have 50 ladies with vaccine hesitant response within the cohort. We have worked with the public health services locally and in the southeast, and we plan to follow up these children to see what their vaccination status is as after they've completed the age limit for the primary immunisation schedule, and we hope to find that this questionnaire is able to act like a good sieve, or is able to highlight those who are less likely to vaccinate. Based on this, we plan to carry out further research to see if certain implementation strategies or certain, I suppose, interventions can increase the vaccine uptake among the vaccine hesitant population. So thank you very much. That's a place I hope we can all get back to by the end of the summer. And that's the last one of my pictures of the cultural attractions in Wexford. Thank you all very much for listening to the presentation. If you want to put in answers to the quiz question, please do, and I'll be free to take questions when this presentation ends. Thanks.
Thank you very much, John. That was great. You've covered a great deal of ground in your talk, both in terms of research and audit and in terms of County Wexford. If I could encourage members of the audience to post questions in the chat box underneath the video screens, that would be great. And then we've got a bit of time for questions, so I'll put those to John on your behalf. John, in terms of the vaccine project that you've just spoken about, you said that you'd had 75% of mothers delivering in the hospital had been recruited. Did the other 25% refuse to take part?
No, thanks very much, Dr. Wallace. Luckily, the vast majority of people that we've approached to be involved in the project have been happy to consent. We have a number of exclusion criteria. Some of them are due to practicality, and then most of them really are due to practicality. So we're excluding mums who aren't conversant in English. We're excluding mums who either themselves are quite unwell or have babies who are quite unwell, or if their baby is transferred out of the unit for being unwell, we're excluding them from the project. And then, so they probably account for maybe 5% of the total population delivered, and then probably another close to 20% are patients that we can't get to, most commonly at the weekend, where we've less study staff available. It's mainly been carried out by our FHOs in the postnatal ward, and obviously they're less in number at the weekend. So that's the most common reason. We maybe out of approaching about 200 mothers, we've had 3 or 4 people that have refused to participate. So we've had a great uptake from those we've approached.
I mean, it's a reasonable response rate, really, and it doesn't seem as if the exclusions would be likely to bias the results.
Hopefully not. It's a bit unfortunate that language is an exclusion, but it would take an awful lot of work to overcome that barrier.
Yeah. And in terms of vaccine hesitancy, what interventions are there? I mean, I think, the instinct of the doctor speaking to the vaccine hesitant parent is to kind of start lecturing them, really, isn't it? Or tell them sort of personal horror stories of, what's happened to unvaccinated children. But perhaps that's not the best way psychologically to win them over.
I think I would agree with you. That's often our first instinct, definitely. I've been in that situation personally. But there hasn't been much work done internationally, but there has been one group in Canada who've looked at focused interviewing and used kind of psychological interviewing techniques. But they have done that on the whole cohort on awards. So looked at all mothers delivering the unit and done a 10 to 15 minute motivational interview with them regarding vaccine uptake. And they have seen small increases in vaccine uptake. Again, in areas where vaccine uptake is reasonably high to begin with, but they were looking at maybe increases from 90% to 95%, that kind of range. I suppose one of the focuses of our study would be to try and flag, just to try and see, can a simple questionnaire flag those who are likely to be vaccine hesitant, so that in future, if we were going to put resources into trying to increase vaccine uptake, that we could focus them on those that were most likely to benefit from many inputs. So motivational interviewing would be one. Another thing that I think is quite important is that many studies will say that the paediatrician is one of the people that parents trust the most when it comes to vaccine information. And I think that's where we, meeting parents on the postnatal ward, or perhaps arranging some kind of intervention over the phone prior to the first set of vaccinations, that's where I think we have an advantage as paediatricians, in that we are a trusted source by most parents.
Perhaps as part of the day 2 check, we ought to incorporate a question about whether the parents have got any concerns about vaccination that they want to discuss with the paediatrician who's doing the check.
Yeah, perhaps. And I think that could be something that we could look at going forward. I suppose if my thoughts would be going forward, that if we find that this questionnaire does what we hope it does, and it does identify the majority of those who are vaccine hesitant, I think we'd need to look at then putting in place, we need to recruit parents in that cohort into some kind of a study to see if interventions were effective or not.
In fact, one of the questions that's come in was, would we try to convince mothers who refuse to vaccinate their babies in the survey? Did we have permission to do that if they gave a sort of vaccine hesitant reply?
No, I suppose at this stage, what our approval really is just to administer the questionnaire and to see, and we're asking parents to give us their consent to follow these infants up and to follow their vaccination records, and the Public Health Service locally have agreed for us to do that. So we're not changing. What we're trying to do as much as possible is to do nothing else, and to not change our usual care for these parents. I tend to, when I'm doing a baby check for all parents, mention vaccination. I know that as part of my kind of health promotion. I know that our nurses our midwives, would do the same thing, but we're not putting in additional. We're not altering what information we give to parents dependent on the response to this questionnaire. We really want to see, does the questionnaire work in picking out the parents who are vaccine hesitant. It's relatively simple. It's really asking parents straightforwardly, are you planning on vaccinating? And logically speaking, it should be a good. It should work, but it just hasn't been proven yet. And there has been no questionnaire trial in a postnatal ward. We tried to make it simple, a single item questionnaire, because ones are tired in a postnatal ward usually, and a long questionnaire just isn't appropriate.
That's very good. On the early onset sepsis project, did you adopt the same approach as in the US study, or have you made any local adaptations?
On the whole, we've adopted the same approach. We've made 2 local adaptations. One was made actually in Holles Street, where we've adopted much of our guidelines from. And so in the US, they observed the children 6 hourly. The children who did not require antibiotics, they performed vital signs checks on the children 6 hourly for 24 hours, and that was it. When it was implemented in our tertiary hospital in our network, they also added in a repeat check of observations at 36 hours, and requested that the children be kept in hospital for 36 hours to be observed. We have kept that change, and we have also, in the first 24 hours, instead of doing observations 6 hourly, we've done observations 4 hourly, I suppose, out of an abundance of caution. But they're the two adaptations that we've made. So we're putting in additional checks over and above what was done in the initial study.
That's great, thank you. On the SCID project, the newborn screening and SCID, if that becomes a universal thing, is that going to be just for children in the risk group, in the traveller population, or is that going to be for everybody? And do you know kind of when it's going to come in?
So the last I heard, I was at a teaching programme with the metabolic unit last week, and they can't give a guarantee, but their understanding is that it should be in place by the end of this year, and it'll be universal screening. So it won't be just for children in the travelling community, it'll be for all children. And so I suppose one benefit of it is that we won't have to go and do the targeted screening. It'll be done for everyone.
With the diabetes audit, I would guess that our numbers have been too small to know if there's been any change in the numbers of new presentations of diabetes during the COVID period. I know that the National Diabetes Register sent out inquiries early in the COVID epidemic saying we're not getting any new diabetes, are they all presenting late, what's happening? So I don't know if there had been a bit of a reduction in the numbers of presentations. I don't know if we're going to be able to look at that from that audit.
Yeah, I suppose, as you said, our numbers, just because we're a reasonably small service, it's always hard to know whether we're picking national trends or not. For example, in our unit over the last number of months, we've had a large number of quite preterm deliveries, making us wonder if this is associated with the COVID pandemic. But when we talk to the transport teams or other teams coming from the larger centres, they've found the opposite. So I think when you have a smaller cohort, it's hard to tell. I know at the start of the first lockdown, there was a significant concern. I was working in Temple Street at the time, and in Temple Street and Coveney, they had seen a significant drop-off in the numbers presenting with newly diagnosed type 1 diabetes. However, I think our local experience is that if you look at our numbers, which, as we've said, are small relative to those bigger centres, there hasn't been a significant difference in the numbers presenting this year versus last year, and there hasn't been a significant change in terms of the severity of the presentations, i.e. children aren't necessarily presenting later than they had been. It's a small scale numbers, so it's hard to know.
Okay. I don't know if there are any more questions from the audience. I think we've kind of looked at all the different questions that there are. So thank you very much for your presentation, and well done. That was good.